the principle of it can be. So, so I'll talk a little bit about the stroke program, and really, we've focused on these 4 areas within the stroke program. So improving door-to-needle time, stroke optimal care obviously is a compulsory, and it's a required score. We have an outreach and telestroke development process, and that really gets to trying to expand the continuum of care, as well as a stroke prevention clinic. I won't spend as much time on those because they're more development. I want to talk a little bit about the protocol. So the first thing that we did in the program committee when they got together was develop this protocol. And I think it took 9 months, maybe a year, to reach full agreement on what that should look like, because so many people, to Johan's comment earlier, you have 6 meetings and you meet once a month or every other week. It just takes time and to make sure everybody's comfortable with it. But did arrive at a protocol, and then started to look at really what are our door-to-needle times, because if you follow the protocol, patients should be getting TPA. TPA is for the non-clinicians in the room, such as myself. I learned about this. It's a clot-busting medication that ideally should be administered to patients within 60 minutes of their last known well, shown to improve outcomes for those patients. So our baseline in 2010 was that 31% of our patients were getting TPA within 60 minutes of arrival to the ED, which sounds like a long time, but it's an incredibly complex process if anybody in here has experience with TPA administration. Over the course of the year and building off some of the things that we'll show, we've been able to move that score to 82, and I actually saw the most recent numbers just from last month, and I think we're now close to 90%. So as you can imagine, across the Allina system, we had hospitals that were, hitting the door-to-needle time goal. They never hit it. We had others that were at 50%. We had others that were just so variable, there was no rhyme or reason to it. And so when we got the group together, this protocol really helped as grounding to understand, well, why is there so much variability? Are you following this protocol? And in the process of doing that, we learned that in fact there's wide variation in adherence to the protocol. And so that's where the performance improvement teams were incredibly valuable in changing some of those things. TPA administration rate is something that we've started to look at now, because in theory, if you're following the protocol, we have a good process for getting those patients in. Why is there still variation in the rate of administration? So as I mentioned, some variability. This is what became known as the mountain graph at Allina. You can see there the door-to-needle time goal of 60 minutes is the yellow bar. And then we have each step in the process. So door-to-needle is the mountain. It's the gray mountain. There's door to labs, which obviously you need the labs before you give TPA, although there's some strange what happened here where you didn't have the labs, but you gave the TPA. So there's things like that in that case you'd go do a case review. But you can kind of see time between ordered and given, and so it's just a depiction. And these are hospitals within the Allina system. And oddly enough, Abbott Northwestern sees more stroke patients than any other hospital in our system. And so the fact that they're the 3rd largest bar across the bottom, that was another interesting learning there. So, and then for the PI geeks in the room, this is a pretty interesting chart. You can see the upper and lower control limits. This is at United Hospital, one of our hospitals in St. Paul, and the trend that they've just in the last 6 months of last year been able to see in improving their door-to-needle time. Pretty dramatic improvement from their baseline. So back to our 2 guys at the bar. I thought I would try to show you, and I hope this works. So what we've been able to develop at Allina, and I think we have an incredible EDW development team, and I think that it's actually incumbent on the service line teams now to really leverage what they've put in place, because our data capabilities far exceed right now our ability to execute on those, but we're working on that. So this is just an example. This is specific to neuroscience and spine, and this is the shared analytics portal. So within this, there's service line, and you can go into any service line. I've chosen to come into neuroscience and spine right now, since we'll talk about stroke. But there's other tools in here a leadership dashboard, there's financial, there is ambulatory, and I can show you some of those things in a moment, but I will show you the stroke dashboard. So this is a tool that is available to any member of the stroke program committee and is widely available to physicians and staff that work within Allina. So this overview tab is really core measures performance. It shows each of the key elements. And what we're able to do, and again, forgive me for not being technical, but all this information is drawn straight from the EDW. And so for those things that are in defined fields and easily pulled, this is essentially real time. It's as quickly as the EDW refreshes. For those things that are abstracted, obviously it takes a little bit more time, but the delay isn't much.
This is ClickView, by the way, for those of you who haven't seen ClickView.
Correct. So if we wanted to look at just one hospital within the system, we can select just one hospital. If we wanted to look at just 2011, it'll refresh for 2011. If we wanted to look at only, what's one to look at? Dysphagia, you can select that. So that's optimal care core measures. It's important. For our TPA process, we built in a door-to-needle time flow within the EDW, and so this is available for anybody. So this is just Abbott data now, and you can see the total number of ischemic stroke patients that showed up at Abbott's ED, whether or not they had a last known well documented. If not, they're not eligible for TPA, so they drop out. Was the last known well within 3.5 hours? Did they receive TPA? Was it under 60 minutes? And if not, why? So this is just for the physicians, the ED physicians, the neurologists, for the nursing care directors. Having this information in near real time at their fingertips enables more analysis than we've ever been able to do before. So it's a pretty powerful tool. We also have readmissions data in there for the readmissions team. And you can see counts, why they were readmitted, and out to what date. So it's a pretty dynamic tool.
Matt, I have a question.
Yeah.
Your protocol development.
Mm-hmm.
Did you develop that from scratch, or did you use a product like B&J or Z?
Yeah, so we certainly consulted guidelines that were available, and fortunately we had 11 to work from within our 11 hospital system, because I think every hospital had a slightly different protocol. So we started with our own protocols, and we're able to kind of cull that down to one or two, but certainly we looked at, so there's researchers and analysts assigned to the team that will go out and look for protocols that are available through journals or even at just sort of UCSF or whatever it might be. So yeah, that was a big part of it. So any questions on the dashboard while I have it up? I'll show you an example for spine care in a moment as well. Yeah.
So all the data was available already, and then you just put the ClickView presentation layer on top of it?
The data was being built into the EDW, but it draws from disparate sources. So some of it comes from our EMR records, some of it is contained in Lawson, depending what you want to look at. So the ClickView dashboard will draw from whatever data is contained in the data warehouse. And I can show you an example in spine where we built in supply chain costs and lab costs, radiology costs. All those things feed from different data systems, but they can be seen and looked at dynamically at the same time using the dashboard. We've been adding, yeah. So what we focused development on is stroke was our first program out of the gate, and so that was an initial area of focus. Spine has a huge impact opportunity for the organization, so within our service line, that was the second. But we've built in, and if I can navigate this successfully enough, I can show you all the different dashboards that are available. And I apologize, this is a little slower than it is when you're on our network. I'm kind of remoting in right now, and so it's a little slower than it would be otherwise. So this is our access point. So just by way of reference, we've built dashboards and metrics, and these aren't just, like I said, blind dashboards built for the heck of it. These are supporting teams that are working on specific outcomes and goals. So we have ambulatory quality measures, so those would be things like diabetes and smoking cessation, and you can look across the 100 or so primary care clinics that we have. There's core measures dashboards, there's census, so you can look at almost real time. There's a leadership dashboard, so I try not to slow this down too much, but this one came as a request directly from our CEO, and he wanted to be able to look at employee engagement scores by hospital, safety scores, patient experience ratings. And again, this gets into a little bit, you measure it all and what are you going to do with it. But from a leadership standpoint, having this information handy, the hospital presidents routinely get into this and compare themselves to others. And I believe that you can drill in to an individual unit. So the managers on the units at Abbott could say, what's our trend look like for employee engagement or patient experience, and they can look at the CV-ICU alone. And so that's a pretty powerful thing for the staff. It's really getting that data out of the EDW and making it available to frontline staff has had pretty powerful impacts. So there's lots of stories about staff even doing their own kind of small PDSA cycle studies and seeing what measures they might be able to improve.
So then you just create the dashboards and then organize them for your program?
Correct. Yep.
And is all running off against the EDW or against subject marks that are leadership data set?
Steve, do you have any idea about that?
Yeah, they build subject marks around each of these.
So another one that's,
So it's just to follow up on that question, so do you have a lot of people who work off against the EDW like Moore had, or is it primarily off?
No, and sorry, let me qualify. Not every one of these is only against a subject mark. There's also a lot that comes in from the board.
And how much of that is centralized within, so there's one group versus embedded across the organization?
Correct me if I'm wrong, Matt, but all of these were developed by Mike's team. Right?
correct. Yep.
They're all on the BBW team.
So you have all the outcomes.
Right. Yep.
And no BOE?
They do have BOE. They use BOE.
As an ad hoc scale,
Yep.
but so you can use either of those? Is that the-
Yep, but there's more and more migration than quickly.
So this is the GOAT tool. I think it's Guided Opportunity Analysis Tool. I'm not sure that ultimately the GOAT was the right acronym for this, but it is what it is. So
That's Kevin Camp.
yeah, I know. Yeah. So if anybody knows Kevin, that fits. But you can see here within service lines, and there's the big purple neuroscience and spine right in the middle of the page. So you can see the coefficient of variation along the y-axis, and then the opportunity in terms of dollars along the x-axis. So this really guides from a macro level what service lines are we wanting to focus on and invest in, and you can drill down. So if we wanted to isolate, let me see here. If we wanted to isolate length of stay, where is it? Maybe that's a bad example. Just neuroscience and spine, just spine, and wanted to look at length of stay for fusions. You can just drill right down in, and there's the doctor numbers.
What about the counts of cases?
Yeah, we can do that too. And actually, I should show you better for spine. I can go into the spine dashboard in a second and show you an example there. So it's a pretty powerful it's a pretty powerful tool for all the service line teams as well as the hospital teams.
So I'd ask the group, what do we call this? This is way, way more than a dashboard. And a dashboard just doesn't do the service. I mean, this is an amazing display of control of what goes on in healthcare. I think we need to develop a way of talking about this. It's not reporting, it's not ad hoc analytics, it's sort of pre-prepared reporting. How would you describe it?
I've described these solutions as analytical applications.
Yeah.
It's not, you're right, it's
Yeah.
not just a dashboard. It's an
Right.
application.
Right.
And it's meant for discovery as well as analytics.
Yeah.
Well, it's a dashboard that's delivered to the actual frontline staff to manage daily operations.
Right.
It's what a plant manager would do if he was managing his plant.
Right.
It's exactly what every machine is.
Right.
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 I mean, it's dashboards, but we tend to think of dashboards as these big,
Right.
these huge things. We're trying now to get dashboards in the hand of every manager so that they actually can manage their daily operations, basically. So it's, it's a level of dashboard that occurs at the people, right at the front line. They know exactly how their operations run.
And quite honestly, the biggest challenge we have is trying to get this out to staff to understand it and use it and be able to help inform operations. Because like I said, the data is there. We just have to leverage it more.
And it's current as of, is it the previous day?
Yeah, 24 hours is current, unless, like I said, there's abstracted elements that need to be brought in separately. But yeah, it's very up to date. For those operational metrics, they're real time virtually.
Man, excuse me.
Yeah.
So are you part of Mike Doyle's team? Or where do you see that in your workshop?
Yeah. No, I'm not part of Mike Doyle's team, in case you can't tell. I love Mike Doyle's team. I work with Mike Doyle's team. My role is the operations lead for the neuroscience service line. And so what I do is work with our physician president to sort of oversee the gamut of things that we work on within neuroscience and spine. A major one of which is clinical program development. And that's where we have kind of a matrix support structure. So Mike's team and those guys come in, and Mike is oversees the data architecture at Allina. So that's where his team fits in. Yeah, yeah. So I can just move quickly. I hope this won't reset. Oh, it went all the way back. Sorry, guys. No, it's stuck. Okay. So I'll just talk about, so stroke, we've had a lot of success in developing protocols and measuring outcomes and moving towards an established process. Spine is really an example where we have a ton of opportunity, and Minnesota as a state has one of the lower costs per Medicare enrollee. The notable exception is in spine care for us, and so that draws a lot of attention from the folks at the Dartmouth Atlas and policymakers, and one of our hospitals, Abbott Northwestern, is one of the largest spine surgery hospitals in the country. So we have an opportunity to address some things. This is just a trend to show the rates of spinal fusions relative to other orthopedic procedures. Again, as I mentioned, there's some significant variation across the country in terms of the rate of spine care. And I won't get into too much detail about some of those things, but why I wanted to talk about spine care is because we have to drive towards a model of more value-driven spine care. And so without the EDW infrastructure and without the clinical teams that we've been able to put in place, we wouldn't even be able to consider begin talking about this. It's a highly lucrative thing. There's lots of large and powerful private groups that are involved in this. And so to do these things, comparative effectiveness research, provide some level of transparency. Without the EDW and the data and the dynamic analysis that we can do, it would be a lost cause. It would be a worthy cause, but probably a lost cause. So if in fact there is if the British Journal has anything on spine effectiveness, I'd love to see that. So really what we're trying to drive towards is value-driven care, not focused exclusively on cutting costs. I think in spine there's a default position where we'll focus on implant costs and we'll really drive the cost of spine care down that way, or we'll focus exclusively on some aspect of quality, and really trying to marry those two things up in our spine program committee right now. So we have work focused on measuring optimal low back pain during the first 6 weeks of an acute event, and so we've built in an optimal care metrics and a scorecard that we've rolled out to our primary care clinics. We're trying to organize a team to develop some consensus on surgical indications for fusions, and that's definitely still a work in progress. As well as even just a care process model for lumbar radiculopathy or a specific episode of back pain. And, you know, I think the payers are actually helping us in this regard because prior auth requirements seem to be increasing for a lot of spinal fusions, and there's increasing talk about a bundle or a warranty payment for an episode of spine care. And so that has allowed us to bring some of our provider groups to the table and start talking about some of these things more than we've been able to in the past. And I think the last 3 points there are well taken in spine and probably well taken in all clinical programs that we're dealing with now. We do have an opportunity to define it for the industry, and I think it's groups like your systems and groups like this at Allina that can help do that for any number of different care processes. So I can show you, I'll show you the spine dashboard because that's a pretty good one too. And I should issue one note of caution. I wrote this down because I wanted to share it word for word with the group. I got an email from one of our doctors who got into the spine dashboard, and he sent this email to me, which I promptly forwarded on to our analyst, but it said, "Matt, I've been looking at the spine dashboard. There's a huge amount of agglomerated data here. Can we put this through a multivariate analysis to identify statistical outliers, types of operations, complications, clinicians, etc.? Someone with a solid knowledge of Minitab, SAS, SPSS can take this to town." So I forwarded it to our analyst and said, what is Minitab? But that's the kind of culture change that I think you actually do want to see, because they're excited to get in there and understand their own data. So that's a positive sign. So this is not yet something that we've rolled widely because we do want to limit, we don't want people to immediately go to I guess, misleading elements, but we've tried to get our arms around understanding spine care in Allina. And so over here you can select the procedure that was done, where it was done, the approach, whether it was anterior or posterior. For those of you that have dealt with spine, all those things will impact selection of hardware, which impacts cost, which may impact length of stay, recovery time, complication rate. So the possibilities and the analysis that we can do here are nearly endless. So it's almost, to a certain extent, data overload, which is where I think Minitab and SAS and some of those statistical analysis tools really will help us pick areas of focus. But identify volume trends, and again, you can drill down by hospital. You can look at length of stay, discharge status, so where did the patient go after they were discharged. If they're waiting to go home, it anecdotally leads to a higher length of stay, or if they don't need to go to a SNF or some other step-down care and they don't have those plans made, it impacts your length of stay. So some of the other things that are available in here is a physician scorecard. So you can go in and pick an individual provider. Their D numbers are here, but we do know who those are, who those physicians are. We don't yet have full transparency in that our names are published, but I do think as an organization that's probably where we're headed at the right time. You can pick the level of the case, the operation that they did. So I'll just pick one at random here. That wasn't a good option. So I don't know the D numbers offhand, obviously, but you can get a sense for the type of analysis that you can do. Have complication rates that you can examine. I don't want to look at just this physician, so I'll take them off there. Some of you in the Minneapolis market, avert your eyes. So you can see complication rates, and we've actually had some pretty significant success at reducing urinary complications for post-operative spine care. That's been one of the major complications. Paralytic ileus as well. Those are two areas where we've seen some clinical improvements. and trying to identify what are the cost implications of those is still a work in progress. And then we do have supply chain data in there. So we can look at costs, as well as built in the average age of the patients, their BMI, whether or not they smoke, if they're diabetics. So it gives you a better sense of the patient profiles, and then patient satisfaction as well. So I think that quote's right on. There's a ton of opportunity to look at any number of things in here. It's just the tip of the iceberg for us right now. Pain management, obviously a big issue in spine care. So we're able to see the trends over time. So, unless there's other questions with that, just thought I'd touch briefly on a few of the challenges that we've encountered over the past few years with service line development. Obviously, there's an initial, that's not my data, or the data's wrong, and so there's some skepticism among our physicians and clinical leadership teams about why we're doing this, and some of that's probably historic. I know our organization has approached service line development a number of times over the years, as I suspect some of your organizations have as well, and I think initially it was truly a cost strategy. How do we control costs and understand some of those things? And really now, the service line development, at least at Allina, is an attempt to put our physicians and clinicians in charge of redesigning the care model. And so I think we've been successful at achieving some engagement using that strategy, and really say to them, help us understand what is best practice. And when that's the approach you take, they've come to the table, sometimes for fear of what will happen if they don't come to the table, and sometimes because the scientist in them is intrigued by the possibilities for this. There's been administrative challenges as well. Anytime you start talking about managing programs across the system, everybody's been vested in building their hospitals. And so in the process of building a program, if you identify we should make investments at this particular hospital, maybe not at that one, because it supports our care model, there's a certain amount of politics to be dealt with as part of that too. Return on investment, anytime you invest in building an EDW and you invest in the service line teams and you invest in all the infrastructure, there's sort of a what's the ROI, how quickly is it gonna come? And that's where I think it requires some leadership fortitude and resilience, because it will come, but it's a time-based phenomenon, and you have to give it time, and you have to bring the doctors along. And so that's a key challenge to be overcome, and help your leadership understand that as they go through. And it really is a culture change. I mean, this information and this data to manage operations in near real time, it's scary because it's available and people haven't seen it before. And so, the transparency that comes along with it and how do we use it to drive change is a pretty significant culture change as well. Physician-led is critical. Having the doctors and the nurses at the table to design this is obviously, we're nowhere without that. Data, underlying data, again, as we saw with the dashboards, if you don't have that, it really limits you, or if you do have it, it really expands what you can do. Invest, I think, in a conversation I had actually with Dr. Burton early in our development efforts, one of the things he told me was make sure that people don't poor boy this effort, because if you do that, you just won't be successful. And I would reiterate that and say that it's very true. To the extent that you can garner resources and investment in this, I think it's a worthy cause. And then it does, like I said, take some time. So just from an industry standpoint, I think the people in this room and the work that we're trying to do, that this can provide a path forward right now in an industry where there is a lot of uncertainty. And so the test for all of us, I think, is to help other organizations and help the people in our organization understand what we're trying to accomplish and really become leaders, not followers in this effort. And hopefully we can go from there. So with that, I would welcome any questions that you have. Yeah.
Just a question, the spine care is an interesting one, because to do it correctly, you have to manage the medical management of spine along with the surgical management.
Yeah.
Have you been able to successfully do that?
We've been working on it, and so Hennepin County, is that right? Yeah. So you're probably aware of some of the health partners changes that they've put in place, and that's, Health Partners is a large payer in our market, and they've put in some medical spine triage requirements before patients can be seen in a surgical practice, and so that's provided some impetus for us to really focus on this. And so what we've done, the approach that we've taken, as I mentioned, was work with our primary care base and our rehab service line to say, within the first 6 weeks of this process, what are we going to do for acute back pain patients? There's exclusion criteria, but generally, no imaging, no narcotics, no referral to a surgeon, physical therapy referrals. So trying to get our arms around what should care look like during that first 6-week episode. And we have a lot of protocols that we're looking at right now for how do you do that, and trying to arrive at a consistent one across our system. There's disagreement even within primary care about appropriate narcotic prescription, and some elements like that. But yeah, certainly the spine program, that dashboard's important, but it's inpatient and it's surgical. And so the program is really trying to look at the whole continuum, especially that medical spine management.
And one other one that's kind of tricky is, this is an area that's fraught with conflict of interest.
Yeah.
And I'm wondering if you have charted your, some measure of the conflict of interest versus supply selection. The problem with spine guys is they've all invented this stuff, and they're in the pocket of the major guys who put the implants out there.
Yeah.
And we're having a hard time even getting accurate conflict of interest statements from medical staff.
Yeah.
I'm wondering, because spine to me is sort of fraught with danger.
Indeed. So where we've tried to take that on is this spine implant advisory group. And so what we've done there is bring together a group of physicians from every major neurosurgeon or neurosurgical or orthopedic spine surgery group that practices in the Allina system, and brought them together not so much to look at supply costs per se, but more to assess the value of new product or new technology requests. And in the course of doing that, anybody that brings forward a new request, it has to be approved by this group before you're allowed to use it in the system, other than on a trial basis. And as part of that, there's a disclosure. And so if you want to use a new Medtronic device and you have a conflict of interest, that will be known to the committee and understood. So it's not a perfect system, but it's a start. And I think that over time, we've already denied a few requests, and it's not been unnoticed at all within the system. But that's the venue where we're trying to get our arms around that a little bit more. Yeah.
Matt, the system that you and your colleagues have built is absolutely amazing. I used to describe healthcare as a black box where we didn't know what went on the factory floor. Now I have to say healthcare, except for Allina, is a black box, and they'll teach it. That's really amazing. In Oregon, they have a very aggressive health information exchange, and the governor, who's an ex-emergency doc, is saying if you're going to see our paid patients, meaning the ones that work for the state and the teachers, you're also going to have to see our Medicaid. And before last year, Medicaid was paying about 60% of the cost of providing the care. We took 11% last October. We're taking 19% next July. So that means Medicaid will be probably paying in the order of 40% of the cost of providing that care. And with health insurance exchange, we think Oregon's going to have half again as many Medicaid recipients, going from 600,000 to 900,000. And if we're going to see the paid patients for the state, we're going to have to see the Medicaid too. So, and Providence is already 15% ahead of the market. I mean, more expensive than the market in Portland. We need to drum out probably 25% out of the cost of our care to even survive in the future. We think we're well better positioned than anybody else in Portland, but the fact is our cost structure is completely inconsistent with the future. So if you look at all the line and these great analytics, can you think, what is the best example of where doctors and the organization and the nurses and all the therapists and the finance people have gotten together to drive cost and maintaining quality out of the system? What's the best example? I just want to make sure that, because this is where we're going, and I want to be able to believe that we really can drive cost out of the system. I mean, not 2% or 3%, I mean 10 times that. I mean 20% over the next several years to show value to our program. Is that realistic?
I certainly hope so. And we're struggling with the same thing. I mean, our working assumption is that we're going to have to be break even profitable at Medicare rates within a few years. And so all of this, the cost aspects, equally important to a certain extent, and trying to understand that. I think the best example from Allina may be actually elective inductions before 39 weeks. And so there's been a major focus on reducing those, and we've had significant success across the system. The numbers are escaping me right now, top of mind, but they've shown clinical improvements as well as significant cost savings as part of that. So, in spine, I think we have significant opportunity. Once we've looked at that dashboard and understood it a little bit more, I mean, if you reduce length of stay, you reduce complication rates, you do a better preoperative job, ideally, you'd ream some waste out of the system as well. The challenge with that, of course, is spine is sort of a thing unto itself, but if you drive down the number of operations, that impacts your revenue. So it almost has to be concurrent with a change in your payment model, and otherwise you're just going to lose money.
Well, a couple of comments, kind of echoing what Dick said. Mike Doyle worked for me at Northwestern.
Okay.
I was lucky enough to hire him.
Yeah.
When Steve started rating me. Mike to go to Allina.
Yeah.
I told Mike, I said, Allina is going to be the next Intermountain Healthcare. And I still believe that. You just reinforced it with all this, So along those lines, I mean, we have to get this out to the industry, right? What other audiences are you going to besides Catalyst? Are you going to HIMSS? Are you going to IHI? Where are you going with this message?
We quite honestly right now probably not as many places as we should or could be. I mean, as we have more tangible examples of improvements, I hope that we have opportunities to do that. And there's presenters at IHI and different areas that we do go to. But appreciate the compliment. That's incredibly high praise to be compared to Intermountain. So.
You guys are on the path, for sure. Yeah. One last question.
Yeah.
So you're a part of the ACO Pioneers.
Yeah.